The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Collis.
Rightio guys, we're back again for the Knee Gurus podcast, and I'm really excited today to be speaking with Jun Matsumoto. Jun is a physical therapist who has studied Oriental medicine in major university, and he's also traveled to the States and studied physical therapy in, I believe, East Washington University, and is a certified therapist in Oriental medicine. And Jun runs his own clinic treating patients in his natural healing clinic in Takashima City on the coast of Lake Biwa, which he believes a beautiful place. And what's really interesting about Jun is that he has a special interest in natural healing of the ACL and sees many patients from around the world and has helped many patients be able to heal their ACL. So we're going to find out a little bit more about Jun and a little bit more about what he does for his patients, and talk a little bit about ACL healing and ACL management. So welcome, Jun, to the Knee Gurus podcast. It's great to be speaking with you.
My pleasure. Thanks for inviting me to your podcast.
No problem. Can you tell us a little bit about your background, Jun? Are you a physical therapist in Japan, or osteopath, or seitai, or?
Actually, I'm not the physical therapist of Western medicine. I'm the physical therapist of Oriental medicine. It's a Japanese only certification. It's called judo therapy. Comes from the judo. So
yes.
we can do first aid. We can do reduction for the fracture. We can do manage for mostly musculoskeletal injuries. But I can't do surgery. That's the difference from the Western medicine's physical therapist. I can do without diagnosis by the doctor. That's the difference.
And just as a side note, that's covered under the Japanese National Health Insurance?
Yes, cover, but I don't use it these days. Our medical insurance system is not good, so I don't use anymore.
And how long have you been practicing as a judo physiotherapist?
It's about almost 20 years.
Right. And when did you start developing this interest in ACL healing?
ACL healing, I had interest in ACL natural healing because in Japan, Dr. Iihara, he's a surgeon in Japanese hospital. Actually, he invented the natural healing of ACL tear. But he didn't write many papers to the world, so many people in the world don't know much about him. But in Japan, he wrote a book about ACL, meniscus natural healing. When I was a student in university, I was reading his book. Then we know many of us Japanese therapists, doctors know about natural healing of ACL tear since around 20 years ago. So.
Wow. I have heard of the Iihara Kawano paper. That he's done maybe two papers. I know there was one in 1994, I think, and he's published another one in 2000. So was he your lecturer at university, or did they just talk about his philosophies and studies?
No, I didn't study from him. I just read his book.
I wonder if that book's available in English. I didn't know he'd actually authored a book.
It's a book, only Japanese book.
Only in Japanese,
Yeah.
Yeah. And what would you say the main meaning or the lesson you learned from that book was?
Uh, his protocol is very interesting. He uses the knee brace, special knee brace, very precise, very strong, precise knee brace, but he allowed the patient to move all range from the beginning, but only prevent anterior translation of tibia. It is a difficult word.
Yep. Yep. That's
This
the
need that,
jack brace, isn't it?
yeah. Mhm. Avoid, prevent anterior translation of tibia. Then his protocol asked the patient to the all range of motion exercises from the beginning. Then he had more than 200, 300 patients. The healing ratio was 70 in 20 years ago. But I didn't, my practice, my job, I can't use such kind of knee brace. Then I was thinking different way for the natural healing of ACL tear. Then I started 10 years ago, some experiment. First, I was using kinesiotaping. Do you know kinesiotaping?
Yeah, of course.
Kinesiotaping, but failed. It didn't work.
Okay.
I also tried modality, like left-right modality,
Mm.
failed. Then I kind of invented exercises. It's called Evo exercises. Uh,
Yep.
it is the evolutionary developmental exercises. These exercises consist of the baby's movement. Babies learn, babies do developmental exercises until they stand up when they are 0 ages, right? Do you know? Like crawling, such kind of exercise. Then I had a hypothesis. If the patients start from mm, developmental exercises, natural healing may happen. I tried. Then, uh, first patient successfully healed by doing Evo exercises.
And so
That
were you
that
getting
is
them in a brace at that time, or they were free to move full range of motion with the exercises?
no brace at that
Okay.
time, beginning, no
Mhm.
brace. 7 years ago, first patients have successfully healed. Then I would keep doing the same protocol about 20, for the 20 patients. But, some patients fall, sleep uh, accidentally. Uh, some old people sleep out, fell off. Then that's why I asked the patient to wear the knee brace. Mhm.
And so, apart from the
So
exercises, were you giving them instructions on what to range to keep their knee in, or they were just allowed to fully straighten their knee and move as much as they'd like?
mm, I asked the patients not to extend the knee completely. Mhm. Then my exercises mostly consist of flexion exercise, not extension, flexion.
Yeah,
So I already knew by bending the knee, torn ACLs can come close to each other.
yeah.
Then by doing flexion exercises, these torn ends, touching each other, I thought this movement can enhance the natural healing of ACL. So mostly my exercises consists of flexion exercise and also focusing on hip joints mobility.
And this discovery of or belief that flexion pushes the torn ends of the ACL together and extending the knee pulls the ACL stumps apart and maybe counter productive to healing. Was that the lesson you learned from Dr. Iihara?
No, this
Was that
theory
something you
is
discovered
my own,
yourself?
my own.
And how did you discover that, or what was the kind of, was there a light bulb moment where you sort of suddenly worked out that the ACL is taut in extension and lacks in flexion, or how did you come up with that theory?
I already knew by the paper uh, the tension of distance or tension of ACL differ from the knee range of motion, right? I already knew. So ACL needs the environment, which is tone ends, should be more closer. Uh, Recently, cross-bracing protocol is famous in the world. They also say about the distance, tension of ACL, right? That's why they
Yep.
choose 90-degree immobilization, right?
Yes, correct.
I already knew 10 years ago, 7 years ago.
Yeah.
Then I was always thinking, why only human beings, Homo sapiens, have ACL tear so easily? We have to know the reason
Mm.
why we are so easy to have ACL tear. Have you thought about it? Do you have any idea?
Yeah, it's a good question. And why is that it's happening much more in females than males? I do know that animals can tear their ACLs, but to be honest, I hadn't put a lot of thought into the ACL tear rates, animals versus humans, but certainly a lot on yeah, females versus males, and also, why it happens so often in skiing in particular. That's my special interest area. Um,
Mhm.
what did you think, Jun-san, as to why the ACL tear rates are so high, and they seem to be increasing? Maybe early specialization in sports is another theory that's been put around. Lack of, I guess, agility and cutting movements in childhood is another theory.
Mhm.
What did you
Okay.
think? What was
I
your...
I have a great interest in the humans evolution, not only for the humans, our including mammals, uh, any other kind of animals evolution. Uh, of course, humans had acquired bipedal walking,
Yep.
which can predispose our body, our ACL, easily to be broken compared to the quadrupedal, right? Like cat. Bipedal walking is risky.
Yep.
But
Makes sense.
our ancestors, like Australopithecus, do you know that? Australopithecus or Neanderthalensis,
Yep.
our
Yep.
ancestors,
Yep.
they couldn't extend the knee completely. They walk the knee bent. They couldn't
Because
extend the knee completely.
they're in the early stage of evolution, and
Yes,
that,
yes.
that was a continuation of evolution, this ability of the knee to fully straighten.
Mhm. Other mammals like cat, lion, elephant, they also can't extend the knee completely.
Interesting.
Only, only humans, Homo sapiens, uh, in this 1 million years ago, Homo erectus, our most recent ancestor acquired complete extension of the knee 1 million years ago. Because by extend the knee completely, we can run faster, we can walk longer.
Yeah.
That's why our knee acquired complete extension. But in complete extension, ACL is the stretch out the most,
Yeah.
right? In tension.
Yep.
So
Correct.
that's why this is a second reason our body, human, Homo sapiens, our knees are easy to be broken. Our ACL is easy to be broken.
Interesting. I
That's
hadn't thought
why,
about that, but it does make a lot of sense.
mhm. That's why I thought we have to, when I have an injury, when we have ACL tear, we have to keep any bend at least 30 degree. That was my idea at first.
Mm. Right. And so then you started 7 years ago restricting people in knee braces, and these were only people who would come to see you after their injury, or were you seeing people from on telehealth, or this is pre-tele, or from around the world, or around other parts of Japan, or initially it was only face-to-face consults?
First, I only do the therapy face to face in Japan, face to face. But Japanese people are very conservative,
Yes.
and mostly they believe in Western medicine doctor, not us, not judo therapist.
Yeah.
We don't have such credibility compared to Western doctor. Then I thought Western people are more open-minded. Then I could speak English. Then I started doing the online sessions through Zoom or Skype. It's about 6 years ago I started. Mhm. Then it
And it,
worked. It worked. It worked.
terrific.
Uh,
Yeah,
I don't
I have
I
been
don't have
following
to
your Facebook
touch.
page. Sorry, I've
All
been
right.
following your Facebook page and seen several success stories from patients all over the world who you've cared for and have achieved a good heal. So it's terrific. Super
Oh,
interesting. And how many patients would you say you've managed through uh, your ACL healing protocol now?
how many, including partial tear, ACL, about maybe I tried 200, more than 200, but not all the people continued, right? Just tried once. Some of them tried just one session or two sessions. They didn't finish all the my course.
Yes.
But 100 people, actually, 100 people, they completed my session, like 3 months, 4 months.
And what sort of healing rates have you had out of those 100 who completed the sessions?
90%, 90, 90.
90%. Terrific. And how are you classifying the healing? Are you doing the MRI at 12 weeks? And do you are you using the ACLOAS healing classification or?
Uh, Recently, I use ACL OAS. How do you say? ACL OAS?
Yeah.
It's a classification of
Yeah.
knee problem, knee injury. I use such classification.
And are you reading the
But
MRIs, or are you asking your radiologist to classify the healing, or are you doing it yourself?
yes, right now I'm writing a paper. Then I ask radiologists for their diagnosis.
Nice.
Then I say 90%, but healing grade are different.
Yes.
We expect torn ACL can grow up to thick fiber, thick and tight fiber. This is difficult. Not all the cases can grow up to the best type of healing. I say 90%, but 90% includes all type of healing. Some of very low grade, not not good grade healing, but it is connected.
Yeah. It
So
seems to be the same. The cross-bracing protocol numbers are similar.
mhm,
And how about your ability to classify tear types and to decide which tear type is most likely to have a good healing outcome or a high ACL OAS, or basically, we call it a gold medal heel or a silver medal heel or a bronze medal heel to keep it
mhm,
simple and have a bit of fun with it. Are you
mhm,
able to look at the MRIs, assess the knee through your clinical testing, and make a decision and say, look, I think you've got a very good chance of getting a good heal. Your ACL is more
mhm,
profoundly damaged. Do you make those sort of decisions, or is there any exclusion category for you as to people who may be better candidates for your healing, or people who may not be as good candidates?
mhm. Uh, in 7 years, I was collecting the data. Uh, then I didn't eliminate any patients. My patients, they can start even 2 months after the injury. I didn't eliminate like cross-bracing report. They eliminate aversion tear, right? But I was,
I think the double bundle avulsion they eliminate, but they'd still
mhm,
allow single bundle avulsion, I guess.
mhm. But I didn't eliminate any cases.
Interesting.
Uh, then I I use Iihara classification. It's very convenient. In the case of simple tear, it is more likely to heal to gold medal healing by my statistics, of
Yeah.
course. But ACL is torn, distracted, how do you say, retracted, or
Yep.
flipped away.
Yep.
In that case, it's difficult. Healing ratio up to gold medal uh, is not high.
Sounds like a lot of crossover
So,
between pardon the pun, between what you're doing and what cross-bracing protocol are doing. There's some differences, but it seems like there's more similarities than there are differences.
can you say again? What is the
Uh,
similarities?
well, the cross-bracing protocol also believes in their philosophy that the more profound the ACL is damaged, they use the terminology gap distance between the stumps of the ACL, and they measure that on an MRI,
Mm-hmm.
and
Mm-hmm.
a gap distance above 6 millimeters. They normally say the chance of getting a good heal is low. Uh,
Mm-hmm.
and then, yeah, as you say, they also look at avulsion tears, other concomitant injuries, uh,
Mm-hmm.
and they're getting better and better, I guess, at classifying those tear types and giving patients a good idea as to what type of heal they can expect before going into the protocol, which sounds like you're getting a pretty good idea of that as well, based on the MRI and the presentation and the mechanism of injury.
Mm-hmm. Mostly, I agree with that kind of thinking,
Hmm.
cross-bracing their protocol. I agree.
Yeah. Yeah.
Tear type decides the healing grade. I agree.
Yeah. Yeah. I think, well, for both of you, that's been quite groundbreaking, is this idea of a spectrum of injury where you can have a minorly damaged ACL through to, a profoundly damaged ACL. And the bracing protocol or restricting extension seems to improve the healing ability along that spectrum. So the lower the damage, shorter the gap distance, the more likely they're going to get a gold medal heel. More profoundly damaged, higher gap distance, maybe they'll only get a bronze medal heel or possibly no heel at all if it's too.
The thing is the bronze medal healing, they can't return to sport. Especially the athlete can return to the level which they used to have, right?
Well,
That's
I
why
don't know if that's, I don't know if I would 100% agree with that statement, because there are some athletes performing at a high level without an ACL. But I know the conventional thinking has been that that you can't return to cutting sports if if your ACL has failed healing, or if it's completely ruptured, or if it's a low grade heel. Of course, the ACL is there for a reason, and in an ideal situation, the more taut the ACL, the thicker the band, the stronger it is, the better the heel or the better the reconstruction, the more likely you're going to be able to return to sport at a high level. But it does seem to be there are people who are able to play sport even without an ACL or with a bronze medal heel. But I understand that's not universally considered, and still many people will be pointed away from returning to pivoting sports with a poorly healed or ACL deficient knee.
Okay. But ideal healing is the gold type of gold medal healing, right?
For sure.
With the bronze medal healing, it is higher risk of relapture.
I think that's, I agree.
That's why we have to think more new protocol to enhance the healing ratio, leading the more higher percentage can grow up to gold medal healing. That's why I'm doing a new protocol these days.
Terrific. Tell us a little bit more about how your protocol has changed over the years, and what your new protocol is, if
I'm
you don't
changing
mind sharing.
the angle range of motion. I used to just prevent 0 to 30 degree extension. But recently, my new protocol allowed the patient 60 to 120. 60 to 120. Average is 90, right? Average 90, but 60 to 120.
Yep.
They can move. They can move their knee. By giving the mechanical stress, repetitive mechanical stress, ACL can grow up to rich collagen fiber. That's what I expect my hypothesis.
I think that's been
Compared to the
proven in research that with the mechanical stress during healing, the collagen fibers will be a bit stronger.
Compared to the immobilization, by doing the immobilization, I think we can't expect collagen-rich fiber. So that's why I'm challenging giving the mechanical stress to the ACL so that ACL can grow, can contain more collagen fiber. That's my new protocol.
Interesting. I do know that the cross-bracing protocol believe that the ACL really becomes lax at 50 degrees flexion, and they do not believe that going beyond 90 degrees into deep bending will necessarily inhibit the healing. It's more that they're concerned with the neurovascular bundle in the posterior knee and bunching that down and perhaps contributing to DVT through or other problems from bending too deeply. So I think it's terrific that you're trying 60 to 120, and it's super interesting. And I'm sure the fellows at the cross bracing protocol will be watching your results with great interest as well. One of the things from having many discussions with Tom Cross and his team is that despite what people may think, they are not zealots thinking that their protocol of 90 degrees for 4 weeks and is the only way to do it. You know, they're on a discovery journey as well, and they're learning more about ACL healing themselves the whole time. So I'm sure they'll be very interested, and I think they wouldn't be surprised if you get great healing rates as well, because you're going deeper than that 50 degrees angle. And I think you are correct that providing some mechanical stress will hopefully help with a stronger healed ligament. Just talking about that mechanical stress, is a person able to walk unassisted at 60 degrees flexion? I know it's a little bit at that range. It can be quite difficult to fully weight bear. Are you having them wear crutches or a single walking stick, or are they just kind of walking on their toes around?
By 60-degree flexion, can't allow weight bearing.
No
They
weight
need to
bearing.
use crutches.
Yeah.
My all the prior protocol, I allow the patient to walk with brace without crutches. So
And
that's
so
inconvenient for the patients. Mm.
so
Patient,
this mechanical stress, uh, how are you getting that mechanical stress into the knee if they're not weight bearing? Is this through the Evo Devo exercises, or is there other?
yes, basically able exercises.
Okay, great. And how often are they doing those exercises? They're doing them every day?
Every day, 3 times.
3 times a day.
Yes, one time consists of 5 to 10 exercises, 30 minutes. 30 minutes times 3 times, so almost 90 minutes a day. It's a lot.
It's a big undertaking. Um,
Mhm.
but yeah, super interesting. And like I said, I think there's a lot more in common with your beliefs and the cross bracing protocol beliefs than there are differences. So
Mhm.
one of the differences I've noticed is in this healing window post tear. I know one of the exclusions that the cross bracing protocol has, it started at about 21 days, 19, 18 days, and they had some successful heals for people that didn't go into flexion until sort of 18 days. But more recently, their study seems to have progressed, and they are almost excluding people if they're straightening their knee for longer than 14, 15 days seems to be the cutoff now, whereas you seem to allow people to begin your protocol a little bit later after the tear. Would that be correct to say?
Uh, my protocol, even I say that in 2 months, I tell the patients, please start my therapy within 2 months since injury. That's what I tell the patients. Mhm.
What if the person has been straightening their knee, or a lot of accident
You know,
emergency will get put in a brace that keeps their knee straight after an ACL if they go to the hospital and see somebody that seems to be the lowest.
yes,
Um,
that's the problem. Many
mm,
patients already straighten the knee
yes,
by having the traditional physiotherapy, right?
yeah, and accident
That's the
emergency care put in a straight knee brace.
right. But I include my I'm collecting the data. I'm comparing the patients who didn't straighten the knee and all and also the patient already have straightened the knee many times, comparing the data.
Right. Oh,
So
that'd be super interesting.
my hmm, 80 patients, my case by my statistics, 10 10 to 15% different compared to the groups. Patients didn't extend the knee, and patient already extended the knee. 15% difference.
15% meaning the people who extended their knee had a 15% lower healing rate?
Lower. Mhm.
Okay.
Not big, it is different, but even the patient who already extended the knee, mm, mostly 6 to 70% can heal.
Interesting.
Because
And
patient, yeah.
sorry, are you planning to publish this in a medical journal in the future in English or Japanese or
Yes,
yeah?
in English, I'm thinking, yeah. Mhm.
And are your patients randomly assigned to a bracing protocol or surgery or no bracing protocol and no surgery?
My patient didn't try cross-bracing protocol. But I'm thinking comparing the data from cross-bracing, that research, I'm trying to design uh, similar, how do you say, classification. Then I
Yeah,
want to compare with cross-bracing the report research paper.
that'd be fascinating. And I know that they are beginning their randomized control trial later this year with 90 patients going, one group going into surgery, the other group going into the cross-bracing protocol. So do you have a comparative arm for your group? So people who did not do your continue under your care, and are you following up in comparison with them?
Are you saying I'm comparing two groups?
Yes. Do you have a control group?
A control group. Mm, Actually, not yet. No. Do you have any idea, suggestion for the control group?
Well, I think from my understanding, the cross-bracing protocol, we're having a discussion, the researchers are having a discussion to have the cross-bracing protocol versus surgery as a control group, or cross-bracing protocol versus no surgery, no bracing protocol, just conservative management. But I understand that Tom Cross got outvoted, and the control group is people going to do surgery. So it's going to be cross-bracing protocol, 90 people, 90 people have surgery, and they're going to compare those two over the next few years. So if you would have, could do a control group through your bracing protocol, I guess, versus conservative management, that would be interesting. But if you were to do versus surgery, I guess you could compare your results with the cross-bracing protocols results a little bit more closely.
Mm-hmm. That's what I'm thinking. Yeah, that's what I'm thinking.
Terrific. And if we can just talk a little bit about that acute phase management after someone's first torn their ACL, because I'm sure there'll be people listening to this who have recently torn their ACL, and they might have come across this podcast through that steep learning curve that people tend to go on after they've torn their ACL. What's your advice for those people to maximize the chance of healing, such as um, should they? We know that we want them to keep their knee bent and out of extension. What other management would you advise for them as far as in Japan? I know usually they will aspirate the knee joint by taking fluid out of the knee to assist with the diagnosis and provide some comfort for patients. Do you believe that has any effect on healing and other common treatment choices such as icing or um,
Mhm.
pain relief medication, anti-inflammatory supplements? Have you developed any beliefs around other ways to sort of maximize the healing and prevent things that might some inhibit the healing?
Basically, ice and rest, compression, rice treatment is the basics. And patients should not walk around. Uh, some of them, after they have ACL injury, stand up and ski again, right?
Yes,
Uh, when when they hear popping sound and their knee, uh, had ACL injury, try stay quiet as possible.
I think
Then
that's
in
good advice.
Japan, yeah, like you say, in Japan, doctors extract the fluid, to test the contamination. If is there blood clot, a Japanese doctor do such kind of thing, but extracting the blood, I think that kind of treatment have bad, uh, not good influence for natural healing. So ask the doctor not extract the blood or fluid from the knee joint. Mhm.
And what about anti-inflammatory medication? A lot of foreigners will want to take
Anti-inflammatory medication,
NSAIDs.
according to some papers, such kind of drug may affect natural healing. So I ask the patients not to take such anti-inflammatory medication. Mm. Have you
And
read about it? Have you read about such kind of drug
yes,
may, right, may decrease the healing ratio?
yeah, it does seem to be more and more research showing that says non-steroidal anti-inflammatories may even inhibit the healing because the
Mhm.
inflammation is the body's natural response. And I guess extending that a little bit further, the fluid that develops in the knee seems to
Mhm.
be um, putting the knee into flexion because it's part of the difficulty people have with straightening their knee. It's
Mhm.
almost like the body, knows what needs to be done. It puts fluid in the knee to keep the knee bent and starts an inflammation response.
Mhm.
And I guess we think we know better. We take the fluid out, straighten the knee, dull the inflammation response that the body's doing. So it does seem to make sense that nature, as you say, over millions of years of evolution, is putting things in place to try to heal the ACL.
Mhm. I call that is natural brace. Natural brace.
Yep,
After the injury, can't extend any. That's the natural brace.
yep,
But
yep.
but one thing, after the injury, they tend to have blood clot, right?
Yes, I'm glad you
Uh,
brought that up. I was just about to talk about you're talking about deep vein thrombosis with blood clot? Or do you mean inside the
yes,
knee?
yes, yes, yes,
DVT,
yes. So some doctors give the patients the medicine. How do you call?
anticoagulant.
Yeah, 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 yeah. Mm, do you think that kind of medicine may affect natural healing ratio? Uh, I
It,
think it affects, but it's risky. Uh, blood clot is very risky. I'm wondering if they should take such medicine or not.
It's a very
But
good question. And I know from having many discussions with Tom Cross, he talks a lot about DVT prevention,
mhm,
and particularly
DVT.
for with skiing, people tend to be, skiing is the number one sport for ACL, and people tend to be at destinations far from their home. They do their ACL, they either have a long train ride, a long plane ride, being the most risky, or even a long drive to get home soon after their ACL.
Mhm,
So that period is, and particularly if their knee is being kept bent and they're not weight bearing, they don't have the natural blood pump to muscle pump, I should say, to return the blood back to the heart. Those people are at high risk of DVT. So I know
mhm,
that Tom Cross and the cross bracing protocol team, their stance tends to be that, it's not worth risking dying just for your ACL. So they're still not sure whether these anticoagulants, the Xarelto or rivaroxaban, uh, will inhibit healing or even perhaps promote healing. Um, but they tend to believe that people should do it if they're going to be going into the bracing protocol, and particularly if they've got a long trip ahead.
mhm. But I think my opinion is 1 week, around 1 week, they can take such medicine.
And we
But
normally restrict for 5 days. 5 days post injury, we say no, no blood thinner.
okay, 5 days. Okay. A lot of people in the world are trying to do the cross-bracing protocol by their own without having such DBT medicine. It's very dangerous. Uh,
Yes, it is.
it's very dangerous. Mhm. So that's why uh, allowing the mobility, like 60 to 120 restricted motion, I think that's more safe compared to the immobilization.
Interesting.
Low, low risky.
Um, and uh, through your sort of journey of promoting ACL natural healing, have you had much pushback from surgeons or doctors or other therapists saying, "Oh, Jun-san, what are you doing telling people you can heal an ACL? Like, you shouldn't be saying these things. People need surgery if they've done their ACL." Or have you had many people try to sort of silence you or create problems for you or make fun of your beliefs or anything?
Mm, many doctors, surgeons, uh, don't believe in natural healing. It's a business. This is a medical business. Surgeon make money by doing the surgery, right? So that's the big problem. Mm. It is better for the patients. They have choice to surgery or to non-operative treatment, conservative treatment. Patients should have the choices. But in the world, medicine is business. Medicine is the business,
Yeah,
right?
yeah, that's true. So, if any of the listeners were interested in coming under your care and going through your protocol for natural healing, what does that look like? You mentioned earlier about the full course of treatment. Is that all done on Zoom, or I notice you've had some people travel from around the world to come and meet you face to face, but you are able to manage people exclusively through Zoom?
People exclusive through Zoom.
Sorry. I mean, do you do take people through your natural ACL healing program all online? How would people?
I, I, I do both. I do, I use online Zoom, for the patients in the world. Uh, but my neighbors, mm, Japanese people can visit me face to face. Then I also comparing the healing ratio, the patient who came to my hospital and the people only have done Zoom sessions. I'm comparing because
Mm,
first I'm trying to reduce the knee joint after the ACL tear.
yes,
It's a kind of chiropractic or how do you say
orthopedic.
such kind of yeah such kind of reduction. My technique may have effect on the healing ratio or not. I'm trying to collect the data
So
now.
that's a manual technique you're doing to the knee,
Yeah,
is that what you mean?
yeah. Manual technique.
And is that a regular treatment or is that a one-off reduction, like a fracture, or is it something you will do weekly or?
There's a subluxation happens after the ACL tear, tiny, uh, like or 5 millimeter or 1 centimeter translation happens. I reduce the subluxation by manual therapy,
Interesting. Yeah, right.
but I don't know the results. I haven't done enough data yet. But in the future, I can tell you.
Terrific. Um,
Then,
Go ahead.
yeah, let me tell you about Evodevo exercises. That's the strong point is correcting the malalignment, like valgus or valgus knee.
Yeah.
How do you say? O X knee. How do you say in English?
Yeah, valgus
Mal,
or varus.
yeah, valgus or valgus knee. By doing the Evodevo exercises, such kind of knee malalignment can be fixed. Not completely, but can be fixed
Improved.
if they continue. So that's the strong point of doing Evodevo exercises.
And these Ever exercises, are they available from your website, or you really encourage people to go through those only in consultation with you?
Mm-hmm. Yeah, I teach
Yep.
the exercises through Zoom
Okay.
also. Mhm.
All right. Terrific. That might be a good point to wrap it up today, Jun-san. It has been a fascinating conversation. I've certainly got a lot out of it and got a much greater understanding about your beliefs. And I'm sure there's many people who listen who will also find it very interesting. And so if anyone is interested in getting in touch with June, on the show notes, I will put his contact details of his website. He's also got a growing Facebook page that I think your Facebook page has about 1,400 members, or maybe 2,000, is it? It's ACL Natural Healing.
Oh yes, more than 2,000. Yeah, not many, but
And people are posting questions on ACL healing, and I know you often pop on there and help people with their questions. So that's another good resource if you wanted to get some information on ACL healing.
mhm.
Uh, and you can also sign up on Jun's website to go through his complete protocol. And perhaps I'm sure you're looking for more people for your research as well.
Thank you.
All right. Well, thanks very much for the time today, Jun-san. We really look forward to seeing the results of your study, and I'm sure Tom Cross would love to have a conversation with you one day to discuss the differences. And there's so much common ground between the two of you. Certainly a lot more than there are differences. So I think you both most certainly are onto something. So hope we can get the word out more and more.
Thank you. My pleasure. My pleasure.
Thank you, Jun-san. So that's it for this episode of the Knee Gurus. We'll be back with another episode in the next few weeks.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myokokogen.